Well, thank you very much for this opportunity to talk with you today about our work, which we've been doing in England, in Oxford, to develop a new patient-reported outcome measure. And I hope that this will be a tool that could be used to fit into the sort of integrated systems that we're talking about throughout the conference here. So I'm going to take the time today to talk a little bit about why we developed this patient-reported outcome measure, what we think it's measuring in terms of the outcomes that really matter to both patients and their carers who are living with multimorbidity and complex care needs. And the work I'm going to be presenting today, I'm going to give a little bit of the background in terms of how we developed this new measure, but I'm focusing on a more recent feasibility study that we've done locally within our Oxford clinical research networks to try out this new measure in the context of a memory clinic service. So these will be patients who are coming for a first diagnosis either of mild cognitive impairment or dementia. And so this work is really the work of a collaborative team between researchers and local clinicians. So to set the context within the English health services, we are approaching around 700,000 people who are now living with dementia, and we know that they are supported by more than 500,000 informal carers. And enhancing quality of life for this patient group and their carers has been identified as a priority both within the English National Health Service and the UK government. And we want to focus particularly on dementia patients because not only do they have a complex set of needs, they're often the seldom heard group. Very often their outcomes are reported by clinicians or perhaps by carers or someone reporting on their outcomes on their behalf. But the kind of measures that we work with, we're really trying to enable people to report on their own quality of life as far as possible. And of course, we can't take their quality of life in isolation of the quality of life of their informal carers. As we heard this morning, it was great to hear how much investment has been placed in the Scottish context for investing in informal carers, because we know that without them, most of the care that's happening for these patients would not be sustainable. And just to signal the wider context, although we are working with patients specifically who have been diagnosed with some kind of memory problem, we know that from the wider context of multimorbidity, very often they are living with more than one long-term condition, perhaps with a very complex set of conditions and needs to address. So the key question that we took into this work were how effective are health and care services in the English context for supporting dementia patients and their carers to live well during the period following diagnosis. If we look at the general body of evidence around how the English National Health Service is working at the moment, the answer for that would probably be not very well. We have a growing body of evidence now that says that because the system was designed very much around treating acute conditions, and the funding streams very much reflect that, that people who are living with multiple long-term conditions very often are facing a highly fragmented system where care is not coordinated and they potentially receive poor emotional support even if they're getting fantastic care in terms of supporting better clinical outcomes. So we know there's a lot of informational lack of continuity, and that the services are reactive rather than predictive, which we know we should be aiming for, and very few, very low levels actually of proper care planning. So the proposed solution to this, as put forward by the King's Fund and now advocated by NHS England, is this house of care model, which is moving in the direction that I think we'll be talking about a lot at this conference, very much thinking about both a partnership model between those who are using the services and the professionals within them, but also thinking about joining up the organizational and commissioning practices to support person-centered coordinated care at the heart of this new model. And from the view of National Voices, one of the biggest patient advocacy charities in the UK, that is the definition of integrated care. It should be person-centered, coordinated, and it should be bringing together the outcomes that matter most to the people who are using the services. And that's the real focus of what we do within the Health Services Research Unit at Oxford. We develop patient-reported outcome measures, which are basically short health questionnaires that allow people to report on quality of life in terms of the outcomes that matter to them. So the work that we undertook starting about 4 years ago now was thinking about are there a good way for capturing outcomes that matter to patients who are living with long-term conditions, potentially multiple long-term conditions? So an earlier phase from this work was really looking at the existing outcome measures, of which there are many, and some might be familiar with well-established measures such as the EQ5D, but trying to get a sense of whether they were really capturing all of the outcomes that matter to patients living with long-term conditions. And this illustration here is my sort of visual representation of an earlier phase of work that we did, working with stakeholders and patients, conducting interviews to ask what are the most important things we should be asking about if we're trying to evaluate services on whether or not they're improving outcomes that matter to patients. And many of the existing measures take quite a lot of focus on functional well-being or outcomes that are related to particular symptoms of particular conditions. But the sorts of things that people were talking to us about were much broader outcomes. It was basically around the idea of, can I still live the kind of life I want to live in spite of the impact of any or all health conditions that I might be living with? And so some of these broad outcomes were around ideas of having control over your daily life, maintaining a level of independence, being confident to manage living with your conditions, being able to still do things that you enjoy, and feeling safe inside and outside the home. And also some of the issues that have been highlighted in more recent research around things like managing potentially quite a complex range of services and different medications. So having to assess the outcome on the burden of services and treatment was also something that's quite important. And certainly something we've already had mention of, things that are hugely important are social outcomes, whether people feel isolated or lonely, if they feel they have enough information about their illness and know where to go for help in managing them. So these were the sort of things we were trying to capture in this new outcome measure. So those ideas were translated into 20 items, 20 questions that now form the long-term conditions questionnaire. And the intention of putting together so many broad outcomes was that we wanted this to be an outcome measure that would be relevant for someone either living with a single long-term condition or potentially multiple long-term conditions, and that those needed to include both physical and mental health conditions. And a key consideration for us was thinking about outcomes that would be relevant both within the National Health Service context, which is mainly where we've worked in the past, but also thinking about integrating care. So thinking about, would these be the sort of outcomes that would matter, say, in a social care context? So it was really important to us to capture a wide range of outcomes that would be relevant for assessing people's quality of life as they move through different parts of a more, hopefully, integrated care system. So the first study that we did to test how well this new questionnaire worked was our initial validation study that was published a little over a year ago. And for that study, we asked quite a diverse sample of people living with a range of different long-term conditions to take the questionnaire, and we looked to see how well it performed as a measure. So does it tell us whether someone is living relatively better or relatively worse with their long-term conditions? So we want to make sure that not everyone's answering the questions all the same, so that it gives us some useful information. But we also want to make sure that we're asking the questions of a very diverse sample so that we know that it is relevant right across the range of people living with long-term conditions. So this is just a snapshot of some of the results from that validation study, which was published in BMJ Open. So we recruited the fullest range of adults aging from 18 to 102 years old, but on average they were older adults. And although we only recruited them on the basis of having one long-term condition, and we tried to make sure that we included a range of conditions that were high impact from their high prevalence, such as diabetes and chronic back pain and depression, we also included recruiting conditions that were high impact but rarer, such as more severe mental health conditions like schizophrenia and neurodegenerative diseases like multiple sclerosis. So we recruited people on the basis of having one condition, but in fact we found that the vast majority of our sample had at least 3 conditions. So this was sort of by default tested in a sample with a high multimorbidity. And in terms of how it performed as a measure, we look at psychometric properties such as internal consistency. So do people answer things in a way that makes sense? How they answer one question, would it make sense in terms of how they answer another question? And also reliability across 2 different test points. So do they answer things roughly in the same way over time if you haven't experienced a change? And so it performed well psychometrically as an outcome measure. And an important thing we wanted to check was, could it distinguish between groups of people that we would expect to be living relatively better and perhaps living less well. So we recruited both through primary care practices and also through the local authority who offered social care services. And in the English context, the threshold for accessing social care from the local authorities is quite high. So this was a group that we expected to have much higher needs. And as we expected, we saw that the range of scores, which range from 0 to 100, 100 being the best score, so living well, we saw much more of the sample recruited through primary care near the top end, but much more of the social care sample at the lower end of the scoring scale. So that suggested to us that within a very diverse sample of people who were living with a lot of different conditions, this is an outcome measure that can distinguish if people are living relatively better or relatively worse with their long-term conditions. So the more recent work, now that we felt fairly confident that we had a measure that works well as a measure, was to think about how it might actually be used within clinical practice. So over the last couple of years, we've tested out the long-term conditions questionnaire in local memory clinics within Oxford and Berkshire, 2 counties, 14 different clinics. And because this was a partnership project with our clinical partners, basically they approached us and they said, we like the look of your questionnaire. It's asking the sort of questions that we think we'd like to be keeping track of in our patients. So can we try to use it in our clinic? But of course, most of our patients don't come without a carer with them. So could we adapt the content to reflect those very broad outcomes that we think also would be very important for asking in our carers? So the first part of the work was very much about going back to interview patients with memory problems and their carers, looking again at the content to see, is this content relevant? Is it capturing outcomes that matter to you in living with memory problems? And then once we were confident that the measure was appropriate for this patient population, and we had a new carer measure, which is very, very similar to the original, but has one additional question on time to yourself. Once we were confident that we had some tools to work with, we distributed surveys through 14 different memory clinics in Oxfordshire and Berkshire who had just been given a diagnosis of either mild cognitive impairment or dementia. And just to give you a sense of who responded to these questionnaires, this is a small feasibility study, so just over 100 people each. Generally, it was an older population with a mean age of 79 for the patient populations. But as we expected, we saw quite a bit of comorbidities within the sample, so most of them were reporting another condition as well as memory problems. And similarly, with the carers, the mean age was slightly younger because this was a mixture of spouse carers and also adult children, but they themselves, many of them, were also living with and managing a long-term condition. In terms of how the LTCQ and LTCQ-Carer performed within those groups. In both groups, we had very high completion rates, so most people were able to complete the 20-item questionnaire in full, and these would have been just handed to them at clinic for them to take home and choose to complete on their own and send back. So one of the questions was, how willing would people be to do that? And we asked whether they were able to complete it on their own or required some kind of help. And we had very high completion rates with 2 or fewer missing items, so we could calculate a score for 99% of the sample for both measures. We also had very few missing data, so that tells us that people are able to answer those questions, and we didn't see any questions that seemed to trouble people or that people found inappropriate. And again, we looked at those psychometric measures to see how well it performed within these populations, again, finding high internal consistency. So here we have the scoring distribution among the memory clinic patients in the blue, and then the score distribution among the carers in the green. And we did compare those to an existing measure, the EQ5D, which is very widely used, and found that we saw a much broader range of scores on our measure than with the EQ5D that tended to skew very highly towards the best health state. So it might be a little bit more difficult to distinguish if people were struggling in particular areas. So these are very new data. We've just finished the study, but this is promising for us that with this patient population and their carers, again, we're seeing a measure that can distinguish between people who are living relatively better with their long-term conditions and relatively worse. So we compared the scores for both the new carer measure and the original LTCQ in the memory clinic population with our original study. And I was slightly surprised by this, that the numbers were very, very similar for the scoring as our primary care cohort, which, if you remember, had more people sort of scoring at the higher end, saying that they were living well with their conditions. And frankly, I was expecting that, having just been given a diagnosis of memory problems, we might see more people scoring less well, but in fact, we saw a very similar scoring profile to that primary care sample. And so it makes us wonder if this measure does have the potential to show if people are deteriorating or living less well, if this measure might be able to capture that, if they might shift more towards the pattern that we saw among the social care cohort in the original validation study. And then in terms of how it might actually be used, we had some feedback from the memory clinic nurses who were administering the questionnaire, and they highlighted that particularly for the carers, that having something in a structured questionnaire form could help to elicit and disclose areas of concern that might have already been raised elsewhere, but that people might have been more reluctant to talk about. So they felt this had real potential as part of normal part of their services that might enable them to identify areas of concern earlier and then link up to other elements of support in the system. So in the local context here, that might be a formal carer support assessment through an organization such as Carers Oxfordshire. So in conclusion, from this first feasibility study of the LTCQ in the practice of a memory clinic setting, we've concluded that patients with mild or moderate memory problems can complete this measure they can self-complete this measure as a measure of living well in the context of potentially quite complex or multiple long-term conditions, and that the companion carer measure also showed promise as a concurrent measure for capturing these very broad outcomes of living well. We did note there were low response rates across the different clinics that were participating, and we noted that because this was part of a research feasibility study, people were being asked to take the packet home and complete it just after they'd received a diagnosis. And on reflecting with this, we think in terms of really integrating with clinical practice, it might be more appropriate to ask people to take the questionnaire before they come in for their appointment as part of their registration process, and then at defined follow-up times. That may be a more meaningful and feasible way to collect the evidence on how they're doing over time. And something that we need to look at for the future is how well or not this measure can actually capture if people are improving or doing worse over time. So we do need to set up some longer-term studies that would capture the responsiveness of the measures. And finally, the work that we're looking to do next, now that we've done this first feasibility study, we are looking at could these measures be used in the wider system of integrated care. So in our local context, social care and health care services are very separate. They are funded separately. So we've had conversations with the local authority that funds social care services to see if they might be interested in trialing this measure, for example, in some of their carer support initiatives, and also looking to see where within the health services, both at primary care and acute care, where this measure could possibly be implemented. But the idea is that we hope that in capturing outcomes that matter to patients and carers that are quite broad, that they would be relevant to the different components across an integrated health and care service. So we have these measures available. We hope that people will use them so that we can begin to generate more of an evidence base around integrated care. Thank you.